I'm Dr. Mike Janicek. I'm a GYN oncologist with Arizona Oncology. I'm also the medical director of the Virginia Piper Genetic Risk Assessment Center. So I kind of wear two hats. I'm a surgeon, I cut on people, I do chemo, and I like to talk about genetics. So this is one of my passionate subjects, but I will focus on the ovarian cancer aspect, and you'll see me making references to other cancer syndromes as well. So I want to thank Myriad Genetics for sponsoring this event, rolling out the big bucks for this. Deidre Maven and Barbara Mo Walker, you raise your hands. Everybody give them a big hand. Thank you very much. And of course, Amy Magaziner Robertson, who organized this whole thing, spent 24/7 for the past how many months organizing this thing? Many months. So raise your hand. Give it up for Amy. Thank you, thank you. I'd like to thank Dr. Larry Geyer for coming to speak to us as well. He's one of our keynote speakers. I'm just the warm-up act. And Diane Hardesty is going to be speaking to us. She's a Lynch cancer survivor, and she'll be introducing Dr. Patrick Lynch. Is Dr. Lynch here yet? Dr. Henry Lynch was originally scheduled to be the speaker. He had an accident, unfortunately, and his son is standing in for him. But he comes from a fine pedigree and is no less an expert on this. In the fall of 2011, I actually had the honor of hosting a lecture with Dr. Lynch and his lovely wife Jane, who unfortunately died 7 months later. But Patrick kind of felt, the apple doesn't fall far from the tree, and he's following in his footsteps, so we're very happy that he could fill in on very short notice. So we're very excited to hear him talk about Lynch syndrome. I mean, what an honor to have a Lynch talk about Lynch syndrome, so I'm pumped up for that. A couple of disclaimers. I thought this was a CME credit, but I guess it's not. But I think the next one in the series will, when we talk about tumor genomics sometime in February. But I'm not currently a paid speaker for any genetics company. As medical director of the program, I try to stay neutral. I am mind controlled by lunches, dinners, and pens. Anytime someone gives me a pen, I become their slave. It's amazing. So I'm glad that it's required reporting when we accept gifts and lunches and pens, because it does control my mind. So I must confess that. But I do work and collaborate with Myriad Genetics. We've got 2 pilot projects going on. I'll touch on that today. Their new MyRisk panel, which I think is exciting, and an online electronic health questionnaire, which I love to talk about other people's ideas of how we're getting genetic information into pedigrees, because it's a very laborious task, and there's new technology out there that I think will make that job easier. So for those of you who don't know, September is Ovarian Cancer Awareness Month, so it would be inappropriate if I didn't speak and focus on ovarian cancer as a GYN oncologist. And then next month is Breast Cancer Awareness Month. And to bridge the gap, the last week of the month is Hereditary Breast Ovarian Cancer Week. And I forget which day, but there's actually a pre-Viver day for those patients with, when is it? October 6th is the pre-Viver day for, I know the Lynch people have their own group going, and I don't know what other organizations out there, but the Force and the Bracketeers here are a very active group getting awareness out about hereditary breast ovarian cancer syndrome. So I think it's appropriate at this time to be bridging the gap between the September and October. So my focus was going to be on ovarian cancer oncogenesis, genetics, and prevention. I'm going to sort of talk about all of them. I have about 200 slides, and then I make some more and I delete them, and half an hour before the talk I put something together. So it'll be interesting to see how this talk goes, because I think there's so much to talk about. So basically, some of the themes I'd like to get across today, if there's nothing else you learned today, is to teach you that ovarian cancer is not ovarian cancer, okay? And then that there is no screening for ovarian cancer. We try to teach that to the residents, the family practice docs out there. How many family practice docs? There is no screening for ovarian cancer. Please don't do screening C125 on your patients. I'll get to that. This is an important concept because that's constantly misperceived in the field of medicine and with patients. The word BRCA is a misnomer. It's becoming more so a misnomer. We're now learning that hereditary breast ovarian cancer syndrome is really just a part of the Fanconi anemia pathway. It's fascinating molecular genetics and the study of DNA repair enzymes. And this will shock the Myriad people. They're giving me dirty looks, but BRCA testing is becoming passé. It's a thing of the past. I'll explain what I mean by that. And pedigrees, Joyce is giving me a dirty look right now. Pedigrees, all that pedigree stuff's becoming a thing of the past. Because, 10 years from now, you'll stick your finger in a Walmart's machine, you get your whole genome sequenced. Forget about your family history, you'll find out all your mutations. And I'm probably correct about this. It may sound like a joke, but think about the way things are going. So these are my themes for today, and let's see if I can incorporate them into an actual formal talk. So first and foremost, one of the concepts that's slowly being accepted and is not sinking into the heads of people, and any residents out there, it needs to go into your heads right now, is that ovarian cancer is not really ovarian cancer. The typical epithelial serous ovarian cancer is now thought to originate from the fallopian tubes, okay? There's a lot of, I'm not going to get into the detailed molecular genetic studies by Chris Crum and others, but the fallopian tube is a very busy highway. There's sperm that goes up, eggs that go down, but also cancer may come from the fimbria and sprinkle down on the ovaries and spread into the peritoneal cavity. That's the current concept for the majority of ovarian cancers. It's a very important concept. You can actually see histologically, and we really learned this from risk reduction surgeries. When the pathologist would look at the ovaries closely, they would see tubal epithelium and then they see it transition into malignancy. So we take out these ovaries that look normal, but microscopically you could see the beginnings of ovarian cancer. So they basically did elegant studies to basically show this is where ovarian cancer comes from. And so there's currently two types of ovarian cancer. And this is hugely important when you're trying to get your head around why screening doesn't work and what we find in the OR. There's basically two types of ovarian cancer. Traditionally, we all learned in medical school that it's an invagination of the surface epithelium, and then some mutations happen, and then you get the cyst, and then it becomes cancer. That's how all of us learned about ovarian cancer. And probably still being taught. I hope Dr. Bula and Borst, when they lecture the residents, are going to start showing this slide, because that's an old concept now. This is still partially true for the endometrioid cancers, the mucinous tumors, so this is still the traditional pathway for those less common tumors. But for the more common serous carcinomas, it's thought that there's abnormalities in the tubal epithelium, and you start getting mutations. They call it the P53 signature, and of course BRCA and other genes are involved in this. And then you get precancer, and then these can sprinkle down onto the ovary and into the peritoneal cavity. Or you can get an invagination of the tubal epithelium called endosalpingiosis and go through that same pathway. But the bottom line is ovarian cancer, the most common type that we typically talk about, is really fimbrial cancer. Interesting concept, and it's true. It's just hard to accept because it's been dogma for so long. Occasionally we'll be in the OR and you can get, we all know there's a primary fallopian tube cancer, but really we're probably just catching a cancer that's in the beginning of becoming ovarian cancer, because biologically fallopian tube and ovarian and peritoneal cancer, they're the same disease. And I think we're beginning to understand now it really all starts in the fimbria, and occasionally you can do a case and see the tumor growing in the fallopian tube fimbria before it spreads too much elsewhere. It's rare that we catch it this early, but we've all seen that occasionally. And in my mind, and the gynecs sitting here today understand this, there's really two kinds of ovarian cancer clinically. We knew this from in the OR. You can get the case where you have this countless tumor nodules and carcinomatosis. This is that type 3 fallopian serous carcinoma that we hate, okay? It presents in advanced stages and is all over the place. Patients present with bloating and difficulty eating. Survival's not so good. And then occasionally we'll get this humongo mass that's solitary, early stage, like those clear cell cancers sometimes. They present with pelvic pain and urinary symptoms, and these tend to have a better survival. So biologically, there's a difference between these two types, and I think we're looking at the type 1 versus the type 2 typically. And so, in terms of you want to catch these earlies, forget about it, It's not going to work if you believe that you go from a progression from a mass to a cyst to this. It's just not true. We all used to think that's the case, but in retrospect, it's all making sense to me now that, we used to stage cancers, stage 1, 2, 3, and 4, and we think of it and it's drilled in our heads that it's a continuum. But really what we're seeing is these type 1 cancers typically present in stage 1 or 2, and these type 2, because the fallopian tube sprinkle cancer cells all over the place from the very beginning, these typically present stages 3 or 4. So it's not a continuum, and if you're going to try to prevent these through early detection and symptom monitoring and all this stuff, and try to find stage 1 disease, you're not going to find it. And I'll cite a study later that proves that point. So these are important concepts, and I'm pretty adamant about it. We need to break our dogma in thinking about ovarian cancer, because this really is, in my opinion, the most credible scientifically and clinically, and makes the most sense. So, we've always learned that tying the fallopian tubes reduces risk of ovarian cancer. I'm not sure how that ties in, because if it comes from the fimbria, why would tying the tube reduce the risk? Maybe it prevents toxins from coming up and doing something to the fimbria. But all of us learned in medical school, those women with tubal ligations have a lower risk, sometimes 50% lower risk of ovarian cancer. What about implications for early detection? Dr. Bula is a friend who's starting a study on getting cervical mucus and trying to figure out, can we detect something in the fimbria, fallopian tubes, before it becomes full-blown cancer? And then, should fimbriectomy replace risk reduction salpingo-oophorectomy? Believe it or not, the Canadians are doing this now. They're saying, well, if it's coming from the fallopian tubes, why take the ovaries in a 35-year-old BRCA patient and make her hormone depleted? Why not just take the fimbria? In this country, there's too many lawyers. Any lawyers here? Actually, Dr. Lynch is a JD. He's a... I have to be careful what I say. By the way, I'll probably offend someone here at this point. I tend to be passionate, outspoken, so if I do, please accept my apologies and just get over it. But anyway, so, but how many OBGYNs out here? Have you all heard about taking the fimbria instead of the ovaries for risk reduction? Some of you have, some of you haven't, so I'm going to be giving a lecture to our OBGYNs at SCA because a lot of them haven't heard about this yet. And even tubal ligation. My wife's going to have a C-section next month, and maybe, it's her, she's the boss, she may decide, but if rather than tying her tubes, she's talking to OBGYN, I got to believe, why not take the fimbria? I mean, knowing what I know, I can't believe we would just do an elective cesarean tubal ligation anymore. Just take the fimbria. You know, we do IVF anyway. No one does those tubal reanastomosis if a woman changes her mind. So I think this is a paradigm shift. This understanding of what causes ovarian cancer is a paradigm shift. It's slow, like everything in medicine, it's slow to sink in, but if I were an OBGYN now, you know, I would definitely, instead of doing a tubal, do a fimbriectomy. The BRCA patient, I'm a little more nervous about. It's not standard of care. We all know if you take the ovaries, you can still get peritoneal cancer, right? And we're all afraid of lawyers, right? Because if you take the ovaries out and they get, or if you just take the fimbria out and they get peritoneal cancer, well, I'm going to get sued because I didn't take the ovaries out. So I think that's the big reluctance, is those darn lawyers. But scientifically, there's a strong argument to, you know, and they're just studying this prospectively now, of course. But the Canadians are doing this. So for the residents out there, you know, this all helps us understand why we don't always see pelvic masses and we see ovarian cancer just all over the abdominal pelvic cavity, and why we see that with peritoneal cancer. It's just a nasty disease that just spreads quickly everywhere. And so how does this tie into the thing about screening? I said I was going to talk a little bit more about screening. And I'm going to say this again. There is no screening for ovarian cancer. Yes, there's screening for cervical cancer and breast cancer and colon cancer, because the definition of screening is you're going to catch it early before you can do something about it. There is no screening for ovarian cancer. I'm not going to cite you all the literature studies, but I think the most important one is the PLCO study. That's a typo there. The Prostate, Lung, Colon, Ovarian Cancer Database. It's a huge database. They looked over 34,000 women, and they looked at CA-125 and ultrasounds for screening, and they wanted to see what the impact was. The United Kingdom has published studies showing that they were finding ovarian cancers at an early stage. If you bother to read the paper on page 14, they mention that they include borderline tumors. So if anyone here thinks that a borderline tumor is a cancer and needs chemotherapy, come right up here and let's duke it out, because it's not. They should never have included borderline tumors, and so that skewed their data. If you look at the pure ovarian cancer data, what this showed is they did initial screening. They had 566 surgeries, and they found 18% invasive cancers using ultrasound and CA-125. 83% of these were stage 3 or 4. This is a prospective screening trial where all these women were getting frequent ultrasounds and CA-125s. They're being monitored, and 83% had advanced stage disease. That's depressing. Then they did a follow-up subsequent screening study. They had 604 more surgeries. They found 42 more cancers. So the ratio of surgeries to cancer is about 20 to 1. You have to operate on 20 women to find one cancer. That's advanced stage. Does anyone want to sign up for that? So in the final analysis, greater than 70% were advanced stage cancer. And what do we tell the medical students? 75% of ovarian cancers are advanced stage. So the bottom line is screening is worthless. You're not finding it in early stages. You're not going to be able to do something about it. And you're going to operate on 20 women for every cancer you're going to find that you would have found shortly anyway. So there is no screening for ovarian cancer. For the primary care docs out there in the OBGYNs, if you're telling patients, let's get a CA-125 and an ultrasound so you won't get ovarian cancer, you're not telling the truth. You're misleading the patient. You're not doing anything to prevent ovarian cancer. And if you don't believe me, just ask yourself this question. Ask any of the gynecologists sitting in this room, do they screen their wives with ultrasound and CA-125? I don't know of a single board-certified gynecologic oncologist, male or female, that screens themselves, because we all know the false positives, endometriosis, and we know this data. So I don't mean to preach too much, but it really kills us. And the OBGYNs get it too. You probably get from the primary care docs. The patient, maybe it's the patient that wants a CO25, and it's elevated. Then we got to get a scan. Well, there's a cyst. Well, how do you know it's not ovarian cancer? Well, let's take you to surgery. That's why you see 20 to 1. Is that really what Obama wants us to do? Operate on 20 women to find a cancer that isn't even caught early? So anyway, that's my spiel on screening. And it gets back to the whole genetic thing, because I'm pounding into your heads. Currently, as of this date, we're still looking for different screening modalities, but the current methodologies don't work. So what else can we do? Well, what about the OVA1? How many of you use OVA1 to screen for ovarian cancer? Come on, I know you do. We get the referrals all the time. How many of you don't know what the OVA1 is? Oh, you're not going to raise your hands. I don't want to embarrass you. OVA1 is a new assay that's FDA approved. It has actually 5 different tumor markers. It's the good old CO25. It's pre-albumin, which we all get on patients once they're admitted, and we're working them up. And 3 other markers. And what they do is they mix it up in a blender, and they come up with some secret index. They don't tell you what, but you just get this number, and it's either abnormal or normal, and then you're supposed to do something with it. So this has been shown to have some value, but it's FDA approved for triaging, not screening. So if you already have a mass and you plan to take the patient to surgery, and you're an OBGYN doctor and you're not sure, should I take this mass? The CO25 was a little bit elevated. I'm not sure. Should I send it to Dr. Borsch or Dr. Bula? What should I do? This OVA1 may be helpful to you. It is not designed to replace CO25 or be a screening test. Why am I harping on this? Because we got 2 patients last week where the primary care doc got OVA1 because maybe the rep came to their office, but they didn't read the fine print and it was abnormal. And then we have to sort out what's happening. Again, it's designed for a triaging tool. So how does this work? I hate slides on sensitivity, specificity, and predictive value because it's so boring, but it is kind of important just to highlight. This test, bottom line, if it's positive, has a 36% chance of predicting cancer. This is a patient with a known mass and an abnormal OVA1. So if you're an OBGYN and you got a 36% chance of cancer, you might want to punt it to the oncologist. And when they did the same analysis, they found cancer 43% of the time. And then the converse is true, and this is where the test is useful. If it's negative and you're an OBGYN and you have a patient with a pelvic mass and the OVA1 is normal, you basically get a green light to go to the OR, and the negative predictive value is 93%, which means there's a 7% chance you'll get burned. You'll go in there and you'll find cancer. That's a reasonable risk. When the GYN oncs looked at the mass and did their evaluation, they only had a 2% risk of being surprised by cancer. But that begs the question, if you're a gyn-onc and the OVA1's normal and you don't, you probably should be referring them back to the OBGYN. So what I'm saying is we have a test now that's a triaging tool that puts your risk of getting burned in the OR and finding cancer, this is the main reason we get consults, to less than 7%. You can quote that to the patients. You'll get burned occasionally, no big deal, we'll help you out and figure out what to do. But that gives you a green light to tell the patient, hey, your OVA1 is negative, the mass, we're not sure what it is, but it's probably not cancer, but there's a 7% chance we'll go in there and we might find cancer. You can see a gyn-onc if you want, but chances are it's not, and it's okay to operate on them. So it's a triaging tool. There's also the ROMA score, the HE4 in combination with the CO25, so it's not as complicated as the OVA1, but the same principle. There's a website where you plug in your numbers and it gives you another index. Bottom line with this assay, if you look at the negative predictive value, it's also 93%. So you can use a CO25 plus an HE4 if you want, or an OVA1, which includes a CO25. But those are, again, triaging tests to help you figure out what to do with a mass. It's not a screening test for ovarian cancer. It was never studied for that. It doesn't work for that. It's only if you already have a mass and you're trying to figure out what to do with it. So bottom line on early detection, you saw the symptom awareness. I always have this thing with the support groups in the organization that say, we should be more aware of symptoms. Like if you've got bloating, just tell your doctor, we'll catch more ovarian cancers. And patients always feel guilty in retrospect that they waited 2 months to report it to their doc. Screening, symptom awareness is important, but frankly, as I showed you in those slides, by the time you got bloating, you probably already have stage 3 disease and ascites. It's only if you've got that big pelvic mass that's pressing in your pelvis that you might catch it early, but those are usually stage 1 and 2. So I don't think the burden is that much on the patients or the doctors. It's like having brain cancer and headaches. You know, if you got a brain tumor removed, you might say, yeah, I've had headaches for the past 2 months. But how many of you had a headache in the past week or two? And did you think you had brain cancer? So in retrospect, all these studies on symptoms awareness are always retrospective. So, oh, of course I had bloating. Yeah, I had this pain. Ah, I should have known I had ovarian cancer. My damn doctor didn't pick it up. It's all retrospective. No one has ever shown that prospective awareness of symptoms. And what are we going to do? Tell women, oh, you feel bloated, go see your doc, you might have ovarian cancer? It's not practical. It's too vague. That's the problem with symptom awareness. So it's frustrating. You guys are probably getting depressed here. This asshole up here is saying there's no screening and ignore symptoms and all this stuff. But I'm kind of setting the groundwork for why I think genetics is really going to help clean things up. So this is informal, so if anyone has any questions, we can slow it down here. And
For these triage tests, does it depend on the size of the mass, the age of the patient, or?
I don't know the details of the initial screening criteria, but obviously, no, I don't know if there was any cutoffs. It was basically any pelvic mass. And if it was some huge fungating mass of the ascites, the patient would be whisk-away. They wouldn't be enrolled in a screening trial. So I actually participated in the HE4 trials. So it had to be sort of an indeterminate mass where there was some elevation and it wasn't obviously a cancer. So, you can get huge benign cysts. So it was basically everything that wasn't obviously cancer, but you don't want to ignore either. It was sort of in that gray zone. Yes?
What about the woman under 50 with the breast cancer? Do you do any special screening for them?
It's a different question. When I mentioned there's no screening, I meant there's no general screening. But if a woman's under 50 with breast cancer, she should get a genetic evaluation. And if she's negative, then there's a difficult question. You have to look at her pedigree. What do you think her residual risk of ovarian cancer is? We sometimes have non-informative genetic testing. That patient may still need risk reduction surgery. I'm actually going to mention a case like that coming up shortly. So to answer your question, it's other questions like you have to do genetics first. You can't just say all women under 50 with breast cancer should get screening. Well, screening for what? Was it Cowden's? Is it BRCA? Is it Lynch? I mean, breast cancer has different syndromes that overlap with it. So it's a complicated question. It's a good question, but it opens up a lot more other questions. Admittedly, patients with a BRCA mutation that don't want their ovaries out or breasts, they do get a more aggressive screening. And we do ultrasounds and CM25s, but I'm not familiar with any studies yet that show it's effective in the high-risk population either. Basically, as soon as your kids are done, you take the ovaries out, is the philosophy for gynecologists, because we've seen patients, I've actually known patients that on screening got cancer. Because ovarian cancer flares within 3 months. So unless you do a test every 2 months, you can't do annual screening for ovarian cancer because it comes on so quickly. So this is from the OCAS group. They talk about symptoms and they have cards and they keep telling the public, be aware of the symptoms. They talk about the 4 symptoms of the bloating, pain, satiety, and urinary symptoms. I always try to throw in, well, what about a family history as a symptom? Why don't we think of family history as an important symptom? And so let's get now into the more traditional lecture on the BRCA and genetics, because I think everyone's expecting me to talk about that. So here's a slide that everybody's probably seen. Of the pie of ovarian cancers, this is an older slide, 10% are hereditary, and most of those are BRCA. And there's some Lynch, and there's BRCA2, most of them BRCA1, and a couple other ones. Well, you know what? This is outdated. This is like passé, okay? Bottom line is they're now thinking 25% of ovarian cancers have a hereditary inherited cause. And we're finding a bunch of lower penetrant genes that aren't BRCA1 or 2 that are actually inherited. And so 25%, 1 in 4 ovarian cancer patients has an inherited mutation, okay? 75% are BRCA1 or 2, and the other 25% are the lower penetrant genes that I'm going to talk about. Elizabeth Swisher in the Northwest United States has done elegant studies on what are these genes. They take like random population or consecutive series of ovarian cancer patients and checked a bunch of genes. And in addition to the BRCA1 and 2, there's a whole host of other genes that are involved in oncogenesis for ovarian and breast cancers. And of course, the Lynch syndrome that we're going to hear about later, ovarian cancer is also part of the Lynch syndrome. So these mismatch repair proteins and these Fanconi anemia pathway I'm talking about are all involved. So there's actually, we have to think beyond BRCA1 and 2 and even Lynch. It's a much, when you're thinking about ovarian cancer and breast cancers. When I attend lectures and people show these slides and pathways, I go, holy shit, I was a molecular geneticist and I can't remember and understand all this. So I'm not showing this slide to impress you or intimidate you, But it is important to realize that this Fanconi anemia, which we learned about in medical school, is a cluster of 15 genes that are involved in DNA damage repair and homologous recombination. And it turns out that some of these other genes that I showed on the list, like BRCA2 is the Fanconi anemia D1 gene. They're the same gene. So if you've got 2 copies of it, and you're homozygous for FANC-D1 gene, you've got Fanconi anemia, early onset, congenital abnormalities. You tend not to get cancer because your ovaries shut down and you have other problems. But if you've got 2 BRCA mutations, 2 BRCA2 mutations, you've got Fanconi anemia. If you've got 1 BRCA mutation, you've probably got hereditary breast ovarian cancer syndrome. So it's kind of cool to understand that, we always think of BRCA, this is unique gene. Well, it's really just one of the DNA repair enzymes in the Fanconi anemia pathway. So you have to broaden our thinking that the BRCA1 and 2, BRCA1 is technically not a Fanconi anemia gene, but it's involved in this cluster, this complex of proteins that are involved in DNA damage repair. So we have to broaden our horizons, and I think as we understand these pathways, you'll see why suddenly these new gene panels start, all these names that you see on these lectures, and I could, it would be a whole other talk to go through each one of these and explain what they do. But the bottom line is all these genes now in this pathway are now showing up on the new generation of panels. So you're going to have to somehow get familiar with them because they'll be showing up on your reports eventually because we are now testing for them. So I've already said ovarian cancer is not ovarian cancer. I've already depressed you and said there's no effective screening. I said BRCA is a misnomer because I'm going to try to explain to you that it's breast ovarian, so it was called BRCA originally because we all talk about breasts all the time. And the title of my talk, after all, is The Forgotten Twins, the Ovaries. So I'm still pissed off that they called it BRCA. It should have been called BRA, breast ovarian. So it's a misnomer. We use it all the time. And I've already mentioned that I think I've illustrated to you that we now need to think of it as the Fanconi anemia pathway. And so we move on. So let's talk about why BRCA testing is now passé. It's old school. Forget Myriad and those people. Just kidding. I'm not saying it's passé. I'm saying we're now going beyond BRCA. So in 1996, what I call generation, right now it's getting complicated. When you say someone had a BRCA mutation, it's very important to start thinking back, well, when did you have it done? Because in 1996, when the first BRCA test came out, I call that now generation 1. But in September of 2001, they came out with a large rearrangement panel because not everything's about mutations. Sometimes genes rearrange and get messed up. So that the Myriad came out with a large rearrangement panel. And in 2006, they came out with a BART, the comprehensive rearrangement, so a more complicated, more expansive rearrangement test. So it's now the 3rd generation of tests. So if you tested a patient before 2001 and told her, hey, good news, you're negative, have a good day, guess what? It's outdated. And if you tested someone for BART, which is pretty new, guess what? You're already outdated. Because remember I said 25% of ovarians are BRCA1 and 2. You're going to miss 25% that are hereditary. So for all of you out there who've done genetic testing all these years, you're out of date. How many of you called your patients and tell them, well, maybe you should be reevaluated to get retested? Some of you try. You better have a database to recall your patients and have a way to call them. Warning to you primary care and OBGYNs out there who don't have that kind of system. If you do this testing and you think you're done and it's fire and forget, you're going to get burned because we're now into the 4th generation of testing. And so be careful out there. In our own genetic risk assessment center, we've had to send mass mailings out and recall, and not all patients call back. And then what is your obligation? How many times you're supposed to call them to remind them? Because guess what? If someone was tested back here with Gen 1 or 2 or 3 and they turned out to have another mutation and you told them you're negative, don't worry about it, have a good day, and they get cancer and there's some molecular genetic hotshot doctor tells them, oh, you've got a P10 mutation or RAD51D mutation, and your doc didn't know about these new tests and they didn't call you and tell you that you had an outdated test, hope they don't come with a lawyer. Haven't heard of any lawsuits yet, but I'm nervous as medical director of a genetic risk assessment center that if we don't stay up on this and we don't go back and look at what we've done, there could be a lawsuit one day because there could be some woman running around there that was told my test, and I can't tell you how many times a patient tells me, well, yeah, I had the BRCA testing done, it was negative. And then I have to find their doc that ordered it, or I have to call Myriad, and we have to and it's sometimes work, and then you find out it was one of these Gen 1 or 2s. It's a lot of work, folks, but we have to do it because we're making progress, and we're now finding more and more genes responsible. And so we're making good progress, but the bad news is everything we've done before is out of date. Yes?
Problems with insurance, paying for this again? How do you do that?
Good question, Joyce. You want to answer that question?
Majority of the laboratories are doing more than just the BRCA1, BRCA2s are also doing pre-verification. So we depend on the laboratory to make those calls for the patient.
But we mean if they got it in 2001 and they're negative, and now you call them back and you say, I want to get the generation 4 test, insurance is not going to pay for that.
Yes, they're covering it.
Well, it's complicated because remember the BART will take you from 1 to 3, and some insurance companies, especially if it's a really strong breast ovarian, you know, you might start with the BRCA1, but you know, for us as oncologists, you know, I've had for years I've not done universal testing on my ovarians. I have not tested all of my ovarian cancer patients, even though it's been mandated by NCCN guidelines, because I know I'm not going to catch all of them. It's only recently, and I'll get to this in my talk, that we've had these expanded panels. It's an exciting time now because I think we're at a point now where we're catching almost everything, not everything, but we made a huge leap forward with these lower penetrant genes. Our understanding is accelerated rapidly in the past few years. That's a good question you ask. I don't know the details of how that works. I know some insurance choice, right? They approve the BART, but not the whole panel. I think moving forward, certainly if you get Gen 4, it's going to be a while before we have any major updates, but certainly all this other stuff we've done the past years, we got to figure out a way to update, especially if there's a strong family history.
I know for us, Blue Cross Blue Shield just came down with, before, unless the patient actually had cancer, they would not cover BART. And so now we just received that Blue Cross Blue Shield will cover a patient if they actually don't have cancer themselves. And now all these people from earlier generation tests, we're having to call them all back for BARTs if it's appropriate for them.
Yeah, it's, I mean, you obviously have a good setup, but you know, again, you have to have an organization that's the eye on the ball with this genetics, because it's, you know, for busy OB/GYN or family practice, if you think you're just going to do the test kit and tell them it's negative, and if they're positive, send them on, you know, or some people just send to the genetic counselors and let us in our center sort out all the logistics, these headaches, but it's out there, so you need to be aware of it, or you need to refer the patients, but please don't just tell patients you're negative with a family history, you know, especially if it's a non-informative negative, and tell them, you know, oh, happy news, you know, because we're not sure yet.
I tell them they're negative for now.
It's a good way to put it. Kind of a negative way, but that's a good one. You'll get it eventually. You'll get something. We'll find something wrong with you eventually, but you're okay for now. Go home.
Yes. What's the data on people with these lower penetrance genes with delicate?
That's $1 million question. You know, what we do clinically, you know, when do you do risk reduction surgery? Because they're lower, by definition, they're lower penetrant. So, you know, and that, then the question beyond your question is what to do with SNPs and these polymorphisms where you've got low-level increased risk, you know, that for those of you that do your 23andMe, and nowadays you can send commercially, find all kinds of things wrong with you. Heart disease, cancer, what do you do with them? So your question's a broad one. You know, the BRCA, the high penetrant genes are easy because you should do something risk reduction. The low penetrant ones, we have no clue yet, and the intermediate ones, I think you just have to look at the family history and answer all the questions. Are you completing childbearing? What are the screening? But are there screening guidelines yet for the low penetrant? I haven't formally seen them. And then it depends on what gene and then what information. Not every mutation is equal. Some mutations with the gene are higher penetrant than others in this intermediate. So it's a good question, but there's no way I can answer that in less than an hour in a comprehensive fashion. So just let me overview these panels, and I'm going to go through this quickly because I hate people that throw slides with a bunch of genes because I can't even, I would take another hour to just go through all of these genes. But BRCA is the assay that was developed at the University of Washington with Swisher's group, and it was really the one that for the gynecologists really opened our eyes with ovarian cancer being more than just BRCA1 and 2. And I remember when I was a med student resident fellow that I was told, and Dr. Borshenbula corroborated this with me, there's no such thing as site-specific ovarian cancer. It's part of the breast syndrome, and that's not true. There actually is site-specific ovarian. So this is the panel of all these lower penetrant genes, and if you look at the list, there's overlap with Putz-Jaeger's, Li-Fraumeni, von Hippel-Lindau, there's Lynch. So there's all these, you know, there's two ways to think of oncology and cancer and genetics, is these by syndrome or by genes, and there's all kinds of overlap. So my brain constantly switching back, and I'm sure the genetic counselors do the same thing. Like when you're looking at a pedigree, you're either thinking of a syndrome, and of course if you're ordering testing, you're looking for genes. And it's challenging. The Ambry folks have a really complicated series of panels, and they call them, Panc Next and Renal Next and Breast Next, and they have a BRCA Plus and an Ova Next, a Colo Next, a Cancer Next. The Ambry does have an impressive panel, and they actually beat Myriad to the punch. Myriad's coming out with their own panel, but you do have to know your syndromes. You have to kind of know what test to order. You have to have a good pedigree and have some background in genetics to even know what panel to order. Or you could just say, I'm going to order everything on the Cancer Next. Everybody gets Cancer Next. I don't have to think about it. And it's just kind of what I alluded to earlier. 10 years from now, whole genome sequencing, forget panels. We'll just look at everything. We have 3 billion base pairs in our DNA. The Bible has 3 million. So we have 1,000 Bibles of letters in our genetic code. And you can scan them all with whole genome sequencing and find mistakes. So these panels are it for now, and they're exciting, but I think 10 years from now, we're just doing panels, like the whole genome thing. Now, I'm actually, the Myriad folks were going to break my kneecaps if I leak this, but it's not a secret. But I'm piloting a MyRisk panel for them. It's going to come out in 2014, right? They're being quiet. They're giving me dirty looks. They're planning my demise. But anyway, I looked this up on the internet, so it's not a secret. But of course, Myriad is going to have to catch up with the panels because, they realize it's not about BRCA1 and 2 anymore. So they have an actionable panel of drugs. These are not just sort of esoteric mutations. These are things, and to answer your question, that are clinically actionable. And they break them down, and this is their slide, nice color codes. And they got the BRCA1 and 2 up here, but if you look down here, these are those lower penetrant genes in the Fanconi anemia pathway, like the RAD51, which actually RAD51 is an ovarian cancer only mutation. So there's someone out there, I haven't seen it yet, but someone out there, I'm going to find a RAD51, and she's going to have just ovarian cancer family, and she's not at risk for breast cancer, and I'm going to think of that professor who lied to me and said there's no such thing as site-specific ovarian cancer syndrome. There is. It's right down here. But there is substantial overlap, and there is breast mainly, and there's not so much over here. In the middle group, you've got Cowden's, which kind of covers all of them. Look at that one. I mean, there's basically every cancer. And then you've got your Lynch panel here that overlaps with ovarian, but not breast. But there is some breast and lobular with the gastric, hereditary diffuse gastric carcinoma, was a CDH1. I mean, I could have Joyce come up here and take 2 hours. How many hours would it take you to go through all these syndromes and really explain the genes? A day, okay. But this is where things are heading, folks, because these are the panels that are coming out now. They're basically making it easier for you that you don't have to really nail down the syndrome. You kind of can get this panel. And I'm going to show you a really exciting example that's already happened to us by using these panels. So keep my talk moving, because I don't know if I'm running over or not, but we'll see. But let's unwind a little bit here and get away from all these genes and mutations, because I don't want anybody to fall asleep and fall off their chair and injure themselves here today. So let's talk about some of the exciting things that happened this year. Earlier in March, and I may be wrong about the date, when the so-called Affordable Care Act was passed, there actually is a provision in there that allows for unaffected people to be tested, as long as you're considered high risk by government guidelines, and you're in a grandfathered plan. That was before Obamacare was passed in March of 2010. So those are the requirements. And yes, I'm a Republican. That was a Freudian slip. That's one of the good things, I guess you could say, came out of the Affordable Care Act, provided it doesn't get struck down, is that now if you're high risk, it's covered by Medicare and other insurance plans, as long as it's grandfathered in, as long as it was there. And Joyce, what percentage is that? Only about 50%, right? I think I read somewhere that applies to about half the patients. So it's certainly not at the point where everybody's going to be covered for genetic testing, but it's going to be easier now to get genetic testing covered. So that's important to know moving ahead. Other news, May, of course, everybody heard about the Angelina Jolie story. Suddenly, BRCA and mutations and risk reduction surgery became part of the news media. Public awareness jumped dramatically in 1 week, then 10 years of us talking to patients and giving lectures and trying to get the word. So I think it was an incredible thing for us. It helps us when I tell patients, you know the Angelina Jolie thing, and they start nodding their head. it makes our job so much easier, and I commend Angelina Jolie for what she did. Also in June, the Supreme Court struck down the gene patents for Myriad, and Myriad assembled a hit squad. They're going to respond to this. But it's a battle. It's another reason I'm not a paid speaker for these companies. I'm staying out of that political mess because it's nasty. But the Supreme Court did strike down the gene patents, but not all of them. Ambry, I think the same day, jumped on it, and on their panels threw in the BRCA1 and 2 genes as part of their panels. But in July, Myriad countersued, and they're gonna come back. So it'll be interesting to see what happens with that legal battle. And then something I just found out this month, actually, Dr. Mathern, is he here today? He sent me an email. I wasn't even aware of this, and Joyce wasn't aware of this. But apparently Cigna passed a rule that says only certified genetic counselors and boarded medical geneticists can offer genetic testing. So Siri and Michelle and Dr. Borson Bula, you guys boarded in genetics and you guys certified genetic counselors? If you get a Cigna patient, guess what? You can't counsel them. And all of the others out there that do it. So of course ASCO sent out a strong statement, but I think what happened is when the Supreme Court struck down the patent and all these companies offered cheaper testing, so many tests were being ordered and not always appropriately that I think Cigna responded to that. Barbara and Deidre, did you hear about this Cigna thing?
Yes, so essentially what happened, there's a company out there called Informed DNA. They're a genetic counseling company that is a company like any company, and they went to Cigna and said, if you want to do this right, you need to utilize us. And so it's not just genetic counselors. They actually want people to use Informed DNA, which is actually in conflict with a lot of our centers that have nurse practitioners that are doing this, or physicians that are doing this. So ASCO immediately came down and smote them. And it really was, there is a company that is a genetic counseling company that has contracted specifically with Cigna for this. So I think it's less about the Supreme Court and more about a corporate interaction.
Interesting, I didn't know that. Yes. Bastards. It's cool stuff. I'm staying out of it because it's getting ugly out there. So I want to talk a little bit about the Angelina Jolie story because that really got me passionate. When she actually had her double mastectomy in February of 2013, she had a reconstruction. I think she had nipple sparing and delayed nipple sparing and reconstruction. Dr. Harrison would know more about what exactly was done. But it wasn't until May 14th that she came out with her op-ed that really shocked the world. She was entitled My Medical Choice. And then, of course, everything followed in Time magazine. And I'm an avid reader of People magazine. That's how I stay up on the celebrity gossip. 2 covers in a row, Angelina Jolie in her story. I mean, when have you ever seen, not even Britney Spears, 2 covers in a row. So this was big for the public. This is great, okay? But it kind of pissed me off. And because when I looked at all these news feeds and I was reading through the media feeds and the internet and all that, it was nothing about breast this, breast that, she's having her breast removed, breast cancer, the Pink Lotus breast cancer in LA, breast this, my breast surgeon, breast. We're so breast fixated. What about the forgotten twins? What about the ovaries? I kid you not, it wasn't until the week after that she said she was going to have her ovaries removed. But in that flurry of message, it was as if BRCA was only about breasts, and that's it. No one mentioned the word ovary. I actually went through the internet and Googled and Binged, and I kept looking for references to ovaries. And it was shock, and I started getting annoyed. And I was giving a lot of TV interviews and radio interviews, and I was getting a little hot about this because I think Angelina Jolie had an opportunity to tell both stories, the breast and ovarian. And I actually researched her pedigree. Her mother, Marceline, had breast cancer. No one talks much about that, and we all know she died of ovarian cancer. But her grandmother also had ovarian cancer, died at age 45, and her great-grandmother died of ovarian cancer at 53, back in 1962, only lived 6 months. 3 generations of women with ovarian cancer, and this isn't a story about ovarian cancer? Excuse me. I mean, I was pissed off because yes, it's self-serving, I'm a gynonc and I'm trying to get the message out, but it's pervasive that this BRCA thing, the misnomer I told you about, is all about breasts. Now, of course, the mother had breast ovarian, and Debbie, her mother's sister, Angelina's aunt, died of breast cancer stage 4, I think 2 weeks after this was announced. So it's sad. I mean, clearly it's about breast and ovarian cancer, but it's not just about the breasts. And it wasn't just me. There's a lot of the ovarian cancer organizations that were upset that the media, that she came out with her people at the Pink Lotus, and she had this whole marketing thing out, and she wrote the story, and the ovarian was just barely mentioned at all. Now Angelina did have her ovaries removed, but that was sort of the after story. It's all about her breasts, and oh my God, Angelina and her breasts. So I want to just talk about basic math with breast and ovarian cancer. And because Angelina in her op-ed said, I removed my breast first, and I'm paraphrasing her, I don't know the exact quote, but she said, I removed the breast first because it was more likely to occur and the surgery was more complex. And she's right, you know, and that's her personal reason. She, you know, there's no, I'm not saying she did anything wrong. But when we counsel patients, it's important to keep in mind breast cancer is 10 times more common than ovarian cancer. So we say 1 in 8 women will get breast cancer, 1 in 72 women will get ovarian. But ovarian is 3 times deadlier. I mean, sorry, the breast has 3 times more deaths, but it's 10 times more common. So that means that ovarian cancer is 3 times deadlier. So when you're comparing the prevalence of the disease and the deaths, you know, breast is more common, but it's not as deadly as ovarian. And that's important when you counsel. And in BRCA patients, okay, breast is 2 to 3 times more common than the ovarian. So you know, Angelina was quoted 87% risk of breast cancer and about 57% risk of ovarian. Depends on if it's BRCA 1 or 2. So roughly speaking, breast cancer is 2 to 3 times more common in BRCA patients. Not 10 times, only 2 to 3, okay? So I don't know what word to use for this, but in terms of if you've got a BRCA mutation, ovarian cancer happening is like 3 to 5 times more potent or more, you know, above its baseline. So you got to factor that into the equation. And remember all that harping I did about no screening, and there's no screening? Well, throw that into the equation. You know, you can get MRIs of the breast, you can follow that, but for ovaries, there's no screening. So when we counsel patients, we don't tell them, oh, get your breast removed, that's the first thing you got to do. We actually do the opposite. We say, well, maybe think about the ovaries. That actually confers a protective benefit, cuts your risk of breast cancer in half if you do it before age 50, and even some data, even postmenopausal, there may be a benefit. So what Angelina's story was brave and good, and I laud her for it, but the message was a little bit different than what we give. She didn't hardly mention the ovaries. The media certainly ignored it. And the message is, well, if I got this BRCA, I got to get my breast removed, and then they might forget about the ovaries. And also keep in mind, when did her mother get ovarian cancer? 1997. Well, the BRCA gene was discovered in 94, BRCA2 in 96, and Myriad came out with its test in 1996, a year before her mother got ovarian cancer. So you might say, Janicek, you're being a jerk. You know, there was only a year, and give them a break. You know, there's no way she knew she was going to get ovarian cancer. Really? Her mother died of ovarian cancer. Now I'm talking about Angelina's mother. So Marcheline's mother died of ovarian cancer. Her grandmother died of ovarian cancer, young age, and she had breast cancer before all this. Hello? Well, Janicek, you're being a real jerk. I mean, we didn't know anything back in 1997. Well, I wrote a paper I co-authored in 1994 when I was a fellow about ovarian cancer, and this is before BRCA became available. And in our abstract, we said, women in direct genetic lineage of family cancer syndromes have up to a 50% lifetime risk of ovarian cancer. So don't tell me we didn't know that. This is in 1994, 3 years before her mother got ovarian cancer, with a personal history of breast cancer and 2 generations with dead from early onset ovarian. And so what I'm trying to say, and I'm not politically correct, and I told you I'd offend someone here, but in none of the media stories or Angelina's story was the dirty secret that this Hollywood actress, her mother was also a Hollywood actress, married to John Voight, she could have had risk reduction surgery just based on her personal family history back then. That would have been standard of care before 1997 when she got ovarian cancer. She could have had BRCA testing the year before or shortly thereafter. And the reason I'm saying this is this came out as a news story, right? Oh my God, there's a BRCA mutation in her family, right? We're in 2013 now. And in 1997, this was available. When her mother got ovarian, had breast, and 2 others. So what I'm saying is, whatever the docs are doing in Hollywood, someone dropped the ball, in my opinion. And this happens then, and it still happens today. There isn't a week or 2 that doesn't go by where another missed opportunity happens. So she could have had BRCA testing well before her death in 2007. And I think she still could be alive today. If her OB/GYN had picked up on the fact that there's all this ovarian, hello, and you've got breast, hello, you know, even before BRCA was out there, you know, we knew in our fellowship training, we knew to look out for this. So her mother sadly could still be alive. And of course, you know, Angelina's not returning my calls anymore since she's hanging out with this Brad guy. But I wish I could talk to Angelina because I'm curious if she knew, if she even knows this. I'm really curious because she doesn't talk about it. If I were her, I would say, damn it, look at me. How come they didn't do this? How come, she loved her mother and dearly. She's actually going to portray her in an upcoming movie. By the way, there's a movie coming out, Decoding Annie Parker. Are you guys hear about that yet? The whole BRCA story. So it's coming out when? Coming up this month. So there's a Hollywood movie now on this whole BRCA thing. But anyway, I get passionate about this because not only because the Angelina story, this dirty secret didn't get told, but this dirty secret happens all the time. And I know there's people out there that know what I'm talking about. Okay? And here's another thing, Hollywood, speaking of Hollywood, right? Because it always takes a Hollywood celebrity to raise our awareness, right? If a regular one of our patients gets cancer and dies, well, that's just another case. Happens to a Hollywood celebrity, everybody pay attention, right? Well, I'm one of the older folks. I see a lot of young people, probably don't even know Gilda Radner, but she died of ovarian cancer in 1990, well before BRCA. But look at her family history. Her mom had ovarian. Look at all this ovarian over here. It actually came from her father's side. So this was sort of the first Hollywood celebrity with hereditary breast ovarian cancer. It wasn't Angelina Jolie. So Angelina's story really isn't new. We kind of went through this when Gilda Radner died. And Gene Wilder, her husband, wrote a book on this, okay? Unfortunately, the only thing that came out of the book is get CA125s. I don't know how Steve Piver let that get put in the book, but every patient I know that ever read Gilda's story knows to get a CA125. And it's like, where did that come from? And those of you who are so young who don't know who Gene Wilder is, Willy Wonka and the Chocolate. Did they have a remake of Willy Wonka? I think they do. Amy's saying I'm babbling and I'm getting boring and I should hurry up, so let's see what I have next here. Okay. Well, here's why I'm so passionate about this. Remember I said the Gilda Radner story, right? We learned our lesson from that, right? No. Well, Angelina, okay, she's out now. We learned our lesson from that, right? Well, this is 2 weeks ago. I was on call, and this is my ghetto pedigree. I actually wanted to show you what it's like to do a pedigree while you're standing there with your hand and your patient's telling you a story. But this is the patient I saw who's in her late 30s. She had a double mastectomy when she's 24. Her mother had breast cancer in her 20s, and her mother just got fallopian tube cancer and lives in Mexico, okay? Her mother's sister had breast cancer in her 20s. Then her grandmother, the patient's grandmother, had breast and ovarian cancer, got breast cancer in her 30s. And her great-grandmother had ovarian cancer and got it in her 40s. And then her great-grandmother's, I'm losing track here, something like that, or great-aunt or whatever, had breast and ovarian. You don't have to be a rocket scientist to figure out there's something wrong with this family, right? I mean, there's another Angelina, almost like Angelina Jolie. You got 3 generations and you've got some breast and ovarian and breast fallopian. I mean, this screams hereditary breast ovarian cancer syndrome, right? Well, I was dismayed to look up this patient. She's had multiple admissions for pelvic pain and this and that. This patient has been admitted in the past 10 years 5 times to a U.S. News and World Report top hospital in the city. And when she was admitted, her H&P, admitting H&P family history is colon. That was on her father's side in Crohn's. Okay, this is 6 years after her double mastectomy in her family history. Okay, so they missed it there. She was readmitted in 2004, family history, non-contributory. Okay? Then in October 2011, she was admitted, family history, no history of cancer. Then finally was she admitted, I don't know who did the H&P, Dr. Bula would know, one of his residents I think or someone, but they did positive for breast cancer, ovarian cancer, and prostate. And that's it. And when I arrived on the call on Saturday, I talked to this one, she was having pelvic pain and they had retained an ovary, some OB/GYN left an ovary in her with this history. And it wasn't cancerous and I don't know actually what happened because I didn't take her to surgery, but it was for pain. But this woman shouldn't be walking around with an ovary, and she should have had BRCA testing already. And she just walked into a hospital 2 weeks ago, and I'm doing my ghetto pedigree standing there like shaking my head saying, holy moly, we just had Angelina, and what I don't understand is I asked the patient, didn't you hear about Angelina Jolie? Well, I don't watch TV and news. So credit to her, she doesn't poison her mind with what's out there. But she was oblivious. And she was admitted 4 or 5 times, and this doesn't even count how many office visits she had. Aren't we supposed to do family histories? Aren't we supposed to listen to our patients? Hello, this happened 2 weeks ago. I'm not making this stuff up. And Dr. Borst knows who I'm talking about. I'm not making this stuff up. And this isn't just a fluke example. I brought this up, and I can give you more examples. I see one urologist in the room, Dr. Tay, who's bored with my talk about breast ovaries, so I'm going to wake him up and talk about prostates. It's not even just about breasts and ovaries. We got to give credit to the urologists out there. If you've got a BRCA2 mutation, you have a 9 times higher risk of getting prostate cancer. I didn't know that until recently. Because for BRCA2, we always think is the wussy mutation. It's not as bad for breast and ovarian, and they're estrogen receptor positive. But for prostate, for Dr. Tay out there and the urologist, it's a bad one. And this paper shows the survival of BRCA2 patients compared to BRCA1 and non-mutant. They have more metastases, more aggressive. It's a badass cancer, BRCA2 and prostate. So if you're a guy out there, remember it's not just about women either. Hey, all the guys out there, wave your hands. We're talking too much about breasts and ovaries. Time to get our pumped up and talk about the men out there. We carry the gene too. It's not sex linked, okay? So we need to start being aware of the prostate factor, okay? So BRCA1 increases at 3-fold. BRCA2 is the bad one for prostate. So I just threw that in there to make Dr. Tay happy. Oh, and he raised his hand. He's awake again.
September is also prostate cancer awareness.
No, it's not. It's ovarian cancer awareness month. That wasn't cleared through us, so let's just get that clear. And part of the news, did you know, I think I sent you the email. A couple weeks after Angelina Jolie's story came out, a British guy had his prostate removed for a BRCA2 mutation. Prophylactic prostatectomy, line them up, Da Vinci robots. Everyone's like, holy, are you kidding me? But you know, this guy was in a study and he was scared and he had a bad family history and he's got a BRCA mutation and he didn't want to get one of those aggressive cancers, so he had a Da Vinci prostatectomy. I'm not sure I can fault the guy. I'm not sure what to make of this. It kind of shocked everybody, but this is where things are going, folks. So anyway, you saw my ghetto pedigree. This is what a progeny-generated pedigree looks like in our risk assessment center. But we also doodle on there because it's just, you can't just do it off the computer. You always have to counsel and talk and doodle on there. But I'm showing this real quick. I'm not going to show too many examples because Dr. Geyer's probably going to have some good clinical examples, and Dr. Lynch, and I'm running over. But real quickly, you got some thyroid and breast here, and you got an ovary here. Oops, no, it was really uterine. We're not sure. And some breast up here. Who knows what this syndrome is? Who said Lynch? Okay. Cowden? Any other takers? She has Cowden. She's got a P10 mutation. So, you know, this is, but this was done on a BRCA plus panel, okay? So we were looking for, we weren't really sure, but we kind of, you can suspect Cowden. But it's nice now that you've got these panels. So it was a BRCA plus panel, but it included the Cowden. So we nailed that one. Now here this gets interesting. Dr. Lynch will be interested in this. You got some colon here, and you got a colon here, and you got some colons. It's got to be Lynch, right? Dr. Lynch? Is it Lynch? If Dr. Lynch doesn't know if it's Lynch, then what? Pardon me? Well, it is Lynch, but maybe not. There was an MSH2 variant, and also we found a P10 variant. And so I think in this side of the family there wasn't much history, but again, these large panels, we picked a P10 and an MSH2. We weren't expecting that. And so with these big panels, the lesson here is we're going to start finding stuff that we weren't expecting. And we really weren't looking at this side. All these people are dead and there's not much family history here. So you can have cancers on both sides of the family. So that was an interesting case. So if you cast a wide enough net, we're going to start finding more stuff. Now, I'm going to end my talk, and to tee it up for the other guys, is I made it sound, oh, this is really cool. We got all these new panels. We're going to find all these new mutations. We're casting a wide net. We're going to find some Cowdens when we weren't expecting it. Well, I'm starting to get a headache. So we're getting some tests rolling in now on these panels. This is an OVA next, right? I'm not going to show you the pedigree. Variant and 2 Lynch genes and a RAD50. Joyce? I don't know what to do with this, so I run away and I pretend like I'm busy and I let Joyce deal with it because I don't know what to do with these variants. We got an NBN gene, 2 variants in that gene. What do we do with that? Of course, you have to look at the pedigree and figure it out. But my point is, as you cast the wider net, you're going to catch more fish that you don't know what to do with. And so it's becoming a headache. So it's becoming fun, but it's becoming scary because we don't know what to do with all this information that's going to be hitting us. So anyway, we don't have much time. Maybe later we can talk about the family health questionnaires, the online tools, that Myriad that I'm helping them pilot, that patients online enter their pedigree information and they spit out this nice little pedigree that's going to be free and available online. That'll make maybe your jobs easier. And I'm not going to have time to talk about BRCA revertance because it's depressing, other than to say we've been talking here all about hereditary cancers. Next time we do this session in February, it's going to be about tumor genomics. But the hereditary cancers predict what happened with cancers, and like BRCA patients are eligible for PARP inhibitors, and we can actually do treatment based on their germline and what kind of tumors they have. Well, it's starting to flow the other way. We're now having these big gene panels, and I met Dan from the Foundation One. They have this humongo 5 million gene, just kidding, 250 gene panel for tumors that include BRCA, that include some of the Lynch and all these others. And they're telling me, and I just met him this week, they're just telling me that they may be able to pick up, because they can tell the allele frequency. When you test tumors for these panels, like the Foundation One, they might be able to tell you and call you and say, or write on the report, we think this patient may have a germline mutation, look into it. Whoa, I mean, we've been doing that with Lynch. The pathologist will look at Lynch tumors and they'll call you and say, or they'll do the IHC and the MSI. But we're now entering an era with these Mogambo gene panels on tumors where we're going to be getting some information back too, without even family history or knowing what's going on. So be ready for that. It's going to be cool stuff. Attend our next seminar when we talk more about this tumor genomics. But what I'm saying is it's all interlapping now, and I don't know who here can keep up. Dr. Lynch, can you keep up? Dr. Geyer? I can hardly keep up with all this information. It's exciting, but this is what I feel like, this dog here. It's too much to drink. So anyway, I'm going to shut up now. I ran a little bit over. I'm sorry, but I told you I didn't know how long this would go. And there were questions. It's your fault. You guys slowed me down. But anyway, so that's it. I hope I didn't overlap with anything that our other speakers are going to talk and kind of teed it up for them. But I'm looking forward to Dr. Geyer. Do we have a little break here, or are we going to go?
Like a couple minutes to switch the mic.
Okay, let's do that. And I guess I can field questions while we're switching equipment and going. Thank you.